Otosclerosis is a process of abnormal bony remodeling unique to the otic capsule, which may result in hearing loss. Let's start our discussion by defining the otic capsule. The otic capsule is a uniquely dense component of the petrous part of the temporal bone. It forms the bony labyrinth of the inner ear structures. The otic capsule reaches adult size at 1 year of age and does not normally undergo further remodeling. This is an artist's depiction of the way in which the otic capsule is embedded in the petrous part of the temporal bone. Let's draw a picture of the hearing apparatus including the otic capsule. The first structure is the tympanic membrane, on which lies the malleus. This articulates with the incus bone, followed by the stapes. The stapes rests on the oval window overlying the vestibule of the otic capsule. Here we have the round window, the cochlea, the rest of the vestibule, the horizontal semicircular canal, and the superior and posterior semicircular canals. We should divide the hearing apparatus into the middle ear and inner ear. The middle ear arises from branchial clefts 1 and 2. The inner ear arises from embryologic mesenchyme. The stapes footplate actually arises from a combination of both of these embryologic structures. In utero, the otic capsule develops as a cartilaginous structure which is later replaced with bone. This occurs at 14 identifiable centers throughout the structure. In most cases, the last center to completely ossify, or sometimes not completely ossify, is located here. This location is called the fissula antifenestrum. The words themselves mean the small slit in front of the window. This location is particularly prone to developing otosclerotic lesions. When it is so affected, this leads to the classic finding of conductive hearing loss in otosclerosis. This is a horizontal section through a temporal bone prepared with H&E staining. Here you can see the stapes resting in the oval window. Let's point out the stapes superstructure, the stapes footplate, the annular ligament in the oval window, and this structure. This is the true fissula antifenestrum, a strip of connective tissue lying in a small fissure in front of, anterior to, the oval window. Next we can see 2 turns of the cochlea. In order to understand the development of conductive hearing loss in otosclerosis, let's draw our own representation of the oval window and the fissula antifenestrum. This is the stapes. This is the oval window in the lateral wall of the vestibule. Here's the stapedius tendon, and here's the fissula antifenestrum. Otosclerotic lesions develop in 2 stages. The first stage, otospongiosis, involves the development of hypervascular lesions that may occasionally be observed on otoscopy as a reddish hue over the promontory. This is known as Schwarzschi's sign, and it looks like this. Schwarzschi looks like this. The reddish hue over the promontory can be seen here. The second stage of otosclerosis involves the replacement of spongy lesions with sclerotic, hyperdense material. This process can extend beyond the initial area of the fissula antifenestrum. It's important to understand that the movement of the stapes is not in an in and out motion like a piston, as most people assume. Actually, the posterior edge of the stapes is relatively fixed due to its attachment to the stapedius tendon, and the anterior edge is relatively free. This leads to movement more like a door on a hinge. As otosclerosis progresses to involve the anterior edge of the oval window, this impedes the motion of the stapes, thereby causing a conductive hearing loss. Here we see, side by side, horizontal sections to the temporal bone stained with H&E, one without otosclerosis and one with otosclerosis. Let's look at the normal specimen first. Here we see the footplate resting in the oval window. It is surrounded by bone of uniform density compared with the rest of the bone of the otic capsule. In the affected ear, we see an obvious hyperdense lesion just anterior to the stapes, centered on the region of the fistula antifenestrum. This represents an otosclerotic lesion extending onto the stapes footplate and impeding its motion. In a similar fashion, let's compare normal and abnormal CT anatomy on axial section through a temporal bone. First, let's look at the normal temporal bone on the left. We can see the stapes here resting in the oval window. Anterior to it, between the vestibule and the cochlea, is bone of normal, appropriate density. In the affected ear, the stapes is here and the oval window is here. Between this and the cochlea is a hypodense, enlarged lesion that represents otosclerosis at the fistula antifenestrum. Though it may seem counterintuitive, the characteristic appearance of an otosclerotic lesion is of a hypodensity because though the material is dense, it is poorly mineralized. Finally, let's discuss what we would expect on audiologic testing of the typical patient with hearing loss from otosclerosis. First of all, sound transmitted by air conduction, which relies on the normal movement of the ossicles, will of course be affected. This is called a conductive hearing loss and is represented by this row of squares. We do not expect sensory neural hearing loss in this disease, which is why sound transmitted directly through the temporal bone to the cochlea, in other words, the bone conduction hearing, is preserved. This is represented by this row of open triangles. Because sensory neural hearing is preserved, we would expect 100% discrimination. The stapedius reflex is movement of the ossicular chain through contraction of the stapedius muscle in response to loud noises. The reflex should be predictably absent in otosclerosis because of fixation at the oval window. We must revise one aspect of our predicted audiogram based on empiric findings of patients with otosclerosis. That is, the presence of an apparent sensory neural hearing loss about 2000 Hz. This finding is known as Carhart's notch. Its explanation is relatively sophisticated, and we'll save it for our advanced video on otosclerosis. Thank you.